What does person-centered HIV care look like? Well, joining me to have a conversation just about that is our good friend Danielle Campbell from AIDS Clinical Trials Group and Lillian Mworeko from the International Community of Women Living with HIV Eastern Africa, and from Gilead Sciences, Alex Kintu. Thank you all for being here, making the time. I want to start with you, Lillian. We talk about putting people first. What does that mean, and how important is it for those of us, like myself, living with HIV, those within the community, that we're represented and we're heard, especially when it comes to trials and clinical trials like that?
It means you put me first. I'm at the center. My priorities are the first that you consider. So for whatever you're planning, I must be at the center and I must be involved from the beginning. Meaning-free involvement, engagement, and ensuring that whatever you determine or you decide, it's me first, and that I'm contributing to the decisions that you take at all levels.
Absolutely, Lillian. Thank you. Danielle, what treatment options are available for pregnant people? You're working with women's health and around this field. For pregnant women, those of childbearing age and who are lactating, what's the latest with this population as far as them being put first?
Oh, I think there's so much excitement globally around the need to protect women and other people who can become pregnant by inclusion rather than exclusion in HIV-related clinical research. It's quite the novelty to see where we've progressed in the most recent, 5 years, up, dare I say 2 years, right? There's been lots of conversation and global advocacy that's really pushed the needle, pushed the envelope to get folks to consider bodily autonomy does not stop when one becomes pregnant. It does mean that you must respect a pregnant person's decision to participate in an HIV research trial. Period. Full sentence. Full stop.
Putting people first.
Correct.
Alex, what treatment options are available for pregnant people, those of childbearing age and those who are lactating? What is the latest for them?
Well, it's, as Danielle said, it's an exciting time right now. For a while, we've tried to figure out the best way to include pregnant women and pregnant people in studies, but there was not a framework that we could do that. But increasingly, there's some guidance and also buy-in from regulatory authorities and some documents that we can use to design studies. And thanks to the efforts of Danielle and Lillian, who are part of some of the GCAGs in the Purpose 1 trial. So this is a trial that is evaluating a 6-monthly subcutaneous option for HIV prevention. And we're borrowing from the advice from advocates and other stakeholders on how best to design these studies. We've been able to use their advocacy to actually include pregnant women in this trial and pregnant people, which means that if the drug is found to be safe and effective, this population will have access to it just like the general population. When you come to think about it, it's very counterintuitive to exclude pregnant and lactating people in these studies because they have a higher likelihood of acquiring HIV. So unfortunately, when you exclude them, it means that they have to wait a much longer time as you collect data in that population before they can actually access that new option, whether it's HIV treatment or HIV prevention.
Lillian, back to you for a minute. What do you believe a person-centered approach to HIV research and care looks like, and how do we achieve that? You've said putting people first means put me first. But when we talk about the care and how we, as it relates to HIV research, what do you think that looks like?
Yeah, it is about understanding that the person is an individual with so many needs, priorities, and that they change over time. And therefore, when you put them first, you're going to listen to them. You're going to make sure that you're not making decisions without consulting them, but also that you're going to take care of their different needs at different times. That, for example, if you're talking about a pregnant woman, today she may come when she's very happy. Tomorrow she may come when she has changed. And when you put her first, you're going to pay attention to all that. And that's why it is important that you even listen. So it is more about listening. It is more about giving more space to that person, to that woman, to that young woman, and making sure that you're not making decisions without them. So it is about them.
At the risk of really oversimplifying things here, this shouldn't be so difficult.
It should not.
This is not a difficult concept here, and I think we have a tendency to want to almost overcomplicate things. You know, when you have such a simple message like put people first, person-centered care, and you go, well, that is pretty straightforward, isn't it? And then people go, no, but there must be more. There must be more.
Why?
What's your take on that?
Why is always the first thing that comes to mind. Why should it be more than what it is? When we say put people first, that means just that. Give an examination to the social and cultural context. Consider those things. Build clinical trials that support those lived experience. You'll have the best outcomes and the best chance of getting a sustained and meaningful uptake of your product, intervention, policy in the same populations that advised.
It's a win-win for everyone, right, Alex?
And it's doable. And
Absolutely.
you know, what's important is incorporating the voice of the people who represent the community, you know, at all stages of research. So in the Purpose 1 trial, we incorporated that voice from the early stages, even before writing the protocols. So GCAG, our community advisory and advocacy group, looked at our protocols before we submitted them to regulatory authorities. They provided input on how to best execute these trials. They gave us things to do, ideas of things to do. They told us incorporate ways of monitoring for social harm. They told us include pregnant and lactating people in the studies. And a couple of other things that we actually put into our protocols, and this will provide very, very helpful information. So when you come to think about it, the advocacy to include pregnant and lactating people means if the drug is found to be safe and effective, it will be available as soon as possible.
Yeah, to follow up on that.
It is about acknowledging that people are informed, they have information, they have knowledge. So you're not just coming. By the way, the things that probably you're looking out for, they already know. So when you make them feel that they are part and parcel, when you place them at the center, when they believe that you're trusting them, they give you all the information. They'll make your work easy.
That your actions also follow that, right? The GCAG is the manifestation of that trust. So it's not just a word and without action, but the implementation is what's most important.
And I know as someone, I'm obviously not a pregnant lactating woman. It'll be shocking to you.
No.
But as someone who's, it's true, as someone who's living with HIV though, I know knowledge is power. When I can understand something in normal speak that makes sense, I'm empowered. I feel good about myself. And that is a win-win for everyone. Alex, can you talk to me about...
But before you go to Alex, I think what you are saying is very, very, very true, because many times people come, they think they have everything, they know everything, and then they forget that the person is more knowledgeable than they are. So when you really come with that is what people-centered approaches, even to research, means that you're coming not as, you're acknowledging that you are coming as an expert, but the person that you're going to engage with is more informed, more knowledgeable, and therefore they are actually, at this level.
And it's about, I think it's a collaborative process, again, between the healthcare provider, between the patient, and between, the companies like Gilead Science that are doing all they can to get on top of this. I want to talk to you, Alex, about some of the primary unmet needs that remain for pregnant people and those of childbearing age that you see.
So I think there's a gradual shift. So first was, how do you include pregnant women and pregnant people in studies? Now we're extending to other groups of people. How do you include a pregnant adolescent? Because that brings another curveball into the, 16-year-olds acquire HIV, or 16-year-olds or 18-year-olds have a high likelihood of acquiring HIV. Yep. So there's a shift again, not just in small spaces, but in regulatory spaces, in the community, of including, of coming up with solutions of how to manage more complex populations. And that will also contribute to, hopefully, ending the epidemic.
What about the children of these pregnancies, though? What's the outlook for children with HIV? You sort of touch on it a bit there, but can you go into that a little bit more?
So, children, the couple of aspects with that. First, if you include a pregnant person in the study, you can answer that question fastest. If that population has access to, say, a new drug for prevention, that person won't acquire HIV, they won't pass it on to the baby. Secondly, one of the other things we've done in the PURPOSE trials is include adolescents aged 16 and 17-year-olds. This is another population that has been historically excluded from studies. Now, that might not directly impact a young baby, but the way we do clinical research and approving drugs, you begin with an adult population, then you move to adolescents, then gradually, based off the information you have, you go to younger age groups. Now that we've included adolescents in PURPOSE 1, we'll hopefully have that data if it's approved. We don't have to go to adolescents, we'll go to younger ages, which means that the babies will get to an option for them hopefully sooner, especially as we come up with newer and safer and potentially easier options to use in people living with HIV.
Yeah, well, listen, Alex and Lillian, Danielle, this has been a really insightful conversation. Thank you so much for making the time. It's been a pleasure chatting with you guys.